Welcome. I have no disclosures for this lecture. Now, some time ago, almost uh, um, 10 years ago, we wrote a challenging paper already, more or less focusing on the individualized approach of the circulation by challenging traditional resuscitation endpoints. And basically, from that, in that paper, we said, well, it's not about getting to a cardiac index. It's not about getting to a CVP. It's not about getting to a blood pressure. It's about getting to adequate tissue perfusion. And so, what we argued is when you have adequate tissue perfusion, these global parameters may be not that important as we think. The challenge in all of this, of course, being so what are indicators of adequate tissue perfusion? And in many cases, and even nowadays in the surviving sepsis guideline, lactate is almost universally seen as a, or maybe even the best marker of tissue perfusion, and increased lactate level seen as the presence of an inadequate circulation. We even challenged the dogma of blood pressure, and we said in our clinical opinion, when you have adequate tissue perfusion, so the markers of tissue perfusion are all normal, we have no problem accepting a blood pressure of a mean arterial blood pressure, like 50. And so trying to focus on tissue perfusion and not on macroscope. The variables that we traditionally use for tissue perfusion are blood pressure, heart rate, urine output, and lactate. And new, or a bit of a new way of looking at old stuff, to be honest, is the saturation of hemoglobin in the superior vena cava or in the pulmonary artery, the SCVO2 or the SVO2. The CO2 difference between the venous compartment and the arterial compartment, popularized by Max Harry Weil in his resuscitation research, when he found a normal arterial CO2 and a very high central venous CO2, and skin perfusion parameters, refill time, temperature, and stuff like that. Lactate came about because the basic godfather, one of the godfathers of critical care, Max Harry Weil, doing a lot of research in mostly cardiogenic shock, said, and in his time, and this is 1979, so that's a long time ago. He said basically, lactic acidosis or increased lactate is a sine qua non of oxygen deficit, presently represent the best single objective measure of perfusion failure. Basically saying everyone with an increased lactate level is in shock. And that hit ground. And to be honest, it hit ground with me as well, because the title of my PhD thesis was all around lactate levels. And I hope you, say, change your opinion a little bit on this as well, as my opinion has changed dramatically. This was something that we tried to bring about in a paper that we published in 2019, where we focused on the 10 pitfalls of lactate clearance in sepsis. Now, I won't go into whether clearance is really clearance, but what we try to address in this paper is that you can have increased lactate level for many more reasons than just inadequate tissue perfusion. And that's a caveat, because if you think that any increased lactate level still represents inadequate tissue perfusion, you try to increase tissue perfusion even more than it already is. You increase the blood pressure maybe even more, fluids, start of butamine, which is, of course, not appropriate if there is no tissue. And so that was the main goal of this paper. It has been cited and accessed a lot of times. So it sparked interest by the readers of intensive care medicine, maybe because they thought lactate, as Mark Tariwal said, is the marker of tissue hypoperfusion, and wanted to learn more about it. When we studied peripheral circulation and how to use lactate in these circumstances, we found something interesting. We had an idea. We said lactate is probably a marker of tissue perfusion very early on, because it's incredibly difficult to find patients where you would say this is totally inadequate circulation, but they still have no lactate. And so in that aspect, Tariwal was probably right. It's very difficult to have shock without lactate. The opposite is not true. And so we said, probably in the beginning there will be lactate due to hypoperfusion, but later on, especially in patients with septic shock, it's probably not the case. It's liver dysfunction, liver not able to clear lactate, it's high production, it's inhibition of enzymes and stuff like that. Many other reasons to have lactate than just hypoperfusion. And we tested this in a small group of critically ill patients with septic shock, and they were all survivors. So we excluded non-surviving patients. And what we found is when you look at the normalization of lactate, so this is like an INR of lactate, this is the normalization rate, 6 hours, 12, 18, and 24. We saw this very steep and rapid normalization in a lot of patients. And then after 6 hours, it weaned off. It still decreased, but at 24 hours, still 50% of the patients had abnormal lactate. These were surviving patients. Now, the interesting thing was that this rapid normalization of lactate coincided with markers of tissue perfusion, like the delta PCO2, a marker of cardiac output, and a marker of skin perfusion, capillary refill. And so it indeed seemed as if the early phase of lactate was indeed hypoperfusion, tissue hypoperfusion, whereas in the latter, maybe other elements played a role as well. And so something else is going on here. Let's say, illustrated by the fact that 50% of the surviving patients still had abnormal lactate hours. And so this is probably not treated with dobutamine and fluids and stuff. Now, why would this peripheral circulation be important? Why could this peripheral circulation serve as a marker of tissue hypoperfusion? Because I think we all agree you don't die of a cold skin or of a not so well perfused skin. That's unlikely to cause death. And so that's a study that we did together with the people in Austria. We looked at the relationship between capillary refill time on the x-axis and the Doppler measurement of blood flow velocity in the liver, kidney, intestine, and spleen. And so this is a marker of, let's say, perfusion of these organs, although you do not immediately measure the actual perfusion. And so what we found is that both in the liver and in the kidney and in the intestine and in the spleen, a longer capillary refill time was associated with a higher resistance index, which relates to a lower perfusion. So lower or more abnormal skin perfusion coincided with lower liver, kidney, intestine, and spleen perfusion. And then you can imagine that patients develop multiple organ failure and ultimately die of their condition. And so when you bring all of this information together, you could come up with a flowchart on how to use lactate in an individual basis in the individual patient. So you start with a lactate of more than 2, which is our upper limit of norm. The first question you should ask yourself, is there a likelihood that this lactate could be the result of something else? And in some cases, that's extremely easy, because if you have diabetic ketoacidosis, if you use medication like, for instance, metformin, if you have an intoxication, very simple, or if you have a thiamine deficiency, or you have a lymphoma. Lymphomas tend to have Warburg metabolism, where they do not metabolize glucose into pyruvate, but immediately, and then into Krebs cycle, but immediately to lactate for their energy production. And so these patients can have very high lactate levels. In some cases, it's not that clear, but if you have doubt, then of course research. We don't give fluids to patient with seizure. We don't give the glutamine to patient with seizure. It's obvious that in these cases the lactate comes from something else, and so act accordingly. And that's interesting, and especially interesting for the context. At least we are working in New York. When I did practice in Bellevue, I found these patients in the emergency room with these crazy lactate levels that were definitely not in shock, and just asked for food or a drink and then left. And so what we did is we did a study where we looked at lactate levels on the x-axis, increasing lactate levels on the x-axis, and survival. And in red is the control group of the lactate study that we did in the Netherlands, where we used lactate to treat patients individually. And we showed that if you use lactate in that context, it could improve survival. We didn't do anything otherwise in the control group. And so this is a perfect, let's say, resemblance of the practice of that time in the Netherlands. What we found is that if we admitted patients with a lactate of more than 10 to the intensive care unit, and there was no reason to believe that this lactate was originating from something else than shock, there was no survival. So every patient with a lactate more than 10 died. Now, we did the same with the patients that we admitted at Bellevue ICU, and you see the huge difference. You have patients with a lactate of more than 20, where their survival is almost 80%. So this is not shock. They're admitted to the ICU. They have incredible lactate levels, but as you can see here, there is hardly any increase in mortality when your lactate is more than 9. And there is not a steep decrease in survival if you have increasing lactate levels. So these patients are very different. And as I told you, a lot of these patients have many endocrinology problems. Like I have money to use insulin 3 times a week instead of every day. A lot of intoxications, alcohol, drugs. A lot of seizures, and so a completely different population than in the shock study that we did in the Netherlands. So this other reason for lactate can be extremely important and should not be treated as if it's tissue hypoperfusion. If that's not the case, so you think there is tissue hypoperfusion, from the available data that we got over all the time that we did these studies, we suggest to look at peripheral perfusion. you have lactate and normal peripheral perfusion, the likelihood that you have abnormal tissue hypoperfusion decreases rapidly. If you are treating these patients, you might even cause harm. That's what we found in the Andromeda 1 study that we published in JAMA. And this is a subgroup analysis of patients randomized to the lactate group or the peripheral perfusion group. And so in Andromeda 1, we compared treating the patient based on lactate levels. It had to either be normal after resuscitation or decrease at least 20% and lactate was measured every 2 hours. Peripheral perfusion group, perfusion treatment was stopped when peripheral perfusion was normal. And so this is the subgroup analysis. So after the first intervention, and so the first measurement of either lactate or peripheral perfusion after this first intervention, see what happens if you keep resuscitating a patient with an increased lactate level, that's this group, but a normal capillary refill time. Because here was continued resuscitation, whether it was fluids or dobutamine or whatever, but the protocol didn't allow to stop resuscitation because lactate was not normal or didn't meet the 20% decrease. The mortality in this group was 50%. Now look at the same group in the peripheral perfusion group where treatment was stopped. So if you had a normal capillary refill time after 2 hours, that's it. And the mortality was 23%, a highly significant difference. Interestingly, there was no difference in the abnormal capillary refill time in either group. And so having an abnormal capillary refill time after your first 2 hours is a very bad thing, whether you have increased lactate levels or not, because lactate was not measured in this group. And the mortality was almost completely the same, 46%, and not very different from this 40%. And so continued resuscitation with normal peripheral perfusion might be harmful to a patient. If you still have doubt, and you think, well, this doesn't really add up, what we suggest is to measure the SCVO2, or the hemoglobin saturation in the vena cava superior. If that one is abnormal, you definitely have a perfusion deficit. If you have a normal SCVO2 and still have doubt, then we suggest to measure the delta PCO2. And if the delta PCO2 is also normal peripheral perfusion, normal SCVO2, normal delta PCO2, then the likelihood of still having perfusion abnormalities is extremely. The delta PCO2 comes from my first study that I did in my PhD research. I was in Brussels with Jean-Louis Vincent. And Jean-Louis Vincent was trained by Max Hariwal. And so we were focused on this CO2, and we studied this delta PCO2 in human septic shock. It came up with a marker of a target of 6 millimeters of mercury, looking at flow or perfusion parameters, the index and SVO2, so PA catheter, and we found that the cardiac index and the SVO2 were lower in patients with a delta PCO2 less than 6 when you compare it to more than 6. And since this publication 6 is used as a threshold in clinical, and changes in cardiac output related to changes in delta PCO2. So a decrease in cardiac output tended to increase the delta PCO2, whereas an increase in cardiac index tended to decrease the delta PCO2. And this has been confirmed in later studies. So you can use the delta PCO2 to, let's say, quantify the likelihood of your lactate being a marker of tissue hypoperfusion. That's something that we also showed in a study that we did in Santiago. What we did is, if you have lactate with markers of tissue hypoperfusion or without, doesn't make any difference. And so we used a hypoperfusion context, SCVO2, delta PCO2, capillary refill time. And so when you have these, we said any of these, we said you have a hypoperfusion context, otherwise non-hypo. And if you then look at the relevance of lactate plus or without, with or without this hypoperfusion context, this hypoperfusion context adds to the severity of your consequences of your increased lactate. So lactate plus hypoperfusion, these patients require more norepinephrine. They require more escape or last resort treatment. Something that they still do in Santiago is high volume hemoturbation, associated with higher mortality, more days on the ventilator, and more days in the ICU. Not all significant, but there was a trend, and given the relationship with the other, it makes sense to see hypoperfusion parameters if you have increased lactate. Now, if you have normal delta PCO2, normal SCVO2, normal peripheral perfusion, and you have lactate, you have to consider whether something else is going on. And so is my lactate, although I thought at the beginning maybe not, but is there still a metabolic parameter that drives this lactate? Gustavo Ospina-Tascon, when he did his research in Brussels with Jean-Louis Vincent, popularized the use of the CO2 over O2 content difference, and came up with 4 subgroups, 2 of them with increased lactate. And so group 1 is a group with increased lactate and CO2 over O2 more than 1, and the other one less than 1, group 2. And here you can see that the survival of group 1 is dramatic. And so if you still think that there is something else going on, that might still be tissue hypoxia, whatever missed reason in this patient, the CO2 over O2 difference could be, say, adding to your quest for, do I have adequate tissue? So if this is all normal, you have to reconsider your thoughts about other points. It's if you have lactate and abnormal peripheral perfusion, or you already have an SCVO2, you clearly have a tissue perfusion component, and you should target this. And this, of course, should lead to a decrease in lactate. I don't think there's a lot of, let's say, disagreement that adequate treatment should result in a decrease in lactate. Because if that doesn't occur, that's not a good sign. That's what Jean-Louis Vincent in a paper in 2016 demonstrated. I'm sorry for the layout, it's a little bit complicated. But what he found in the 96 studies that he at that time found in literatures doing at least 2 lactate levels, he found that a decreasing lactate over time is a good sign. And an increasing or not changing lactate over time is a bad sign. And so when you do your treatment, increase flow by whatever means, fluid, butamine, phosphodiesterase inhibitors, whatever you want to use, lactate should fall. And after lactate falls, I think, given the result of the subgroup of Andromeda, we should stop and just observe. If nothing happens, I would measure a delta PCO2 just to make sure that you have adequate cardiac output. If your delta PCO2 is normal, then basically you could try to do the CO2 over O2. But if that doesn't help, then you still have to reconsider. Did I eliminate the septic focus, for instance? Did I miss a septic? Are my antibiotics adequate? Questions like that need to be asked at this point. If you increase flow and your peripheral perfusion or SCVO2 improves or normalizes, but your lactate doesn't change, and your delta PCO2 is abnormal, you didn't do enough. So you have to work harder on improving. If also, again, delta PCO2 normalized after your additional treatment, but lactate doesn't change, something else is going on. You could do the CO2 over O2, but most likely in clinical practice, something else is going on and you missed something. So this is the complete algorithm that was published in the 10 pitfalls of lactate. Now, I didn't go into what you should do. I just said you have to increase flow when this is the case. This is a very nice review and plea for personalization of the hemodynamic management of, in this case, septic shock. This review was led by Daniel de Bakker and recently published in Critical Care. So what they use as a starting point is the cardiac output, so the tissue perfusion adequate, as marked by capillary refill time, lactate, SCVO2, and the delta PCO2, like I did in my previous slides. And then they go into what we should do, could do, and then they go into food responsiveness, left ventricular outflow fraction, left ventricular dysfunction, and right ventricular dysfunction. And I would absolutely encourage you to read this paper because it's very helpful on choosing what to do if you assess in your individual paper that patient that perfusion is not adequate. So in conclusion, the traditional markers, tissue perfusion, that we use are most likely inadequate, requiring context, and are limited in time. Optimizing tissue perfusion in the absence of abnormal markers of tissue hypoperfusion is probably a bad strategy. The optimal way how to do it is still in muddy water. However, presence of tissue hypoperfusion is a clinical emergency. Thank you very much for your attention.